Good morning, everybody, for Cardiology Grand Rounds. Very pleased this morning to introduce Husong Chung, who many of you know as our cardiologist, noctensivist, and nocturnist at the University of Washington Medical Center. So Husong received his Bachelor in Science in Biology and Philosophy from the University of Michigan at Ann Arbor, and then went on to medical school at Wayne State University, where he was a Sarnoff Research Fellow, then making his way here to the University of Washington for his cardiology fellowship. And I think he brings a really interesting perspective because since joining the faculty and for really a decade now, he has helped lead our noctensivist and nocturnist cardiology services. And so I'm pleased to hand it over to him to share with us his perspective of circadian rhythm in cardiology and presumably filtered through his experience of living on the flip side of the circadian cycle. So thanks for joining us, Husong, and please take it away.
Thanks, Greg, for that great introduction. Obligatory disclosure slide. There are no disclosures other than I work at night, as Greg was commenting on. I want to start today by talking about three broad areas of circadian rhythms in cardiology. First, I'll review circadian rhythms in cardiovascular disease. Then I'll talk about circadian rhythms that exist with respect to cardiac care. Finally, I'll shift to cardiovascular consequences affecting those that buck the circadian rhythm like myself, shift workers like myself. I'll kind of give you this brief nightlife view to set the stage for some of the things I will discuss today. Usually my shifts at night go from 7:30 to 7:30, so I'll get there and do sign out, and if there's time, I'll round. This is kind of a hopefully not that typical shift, but does bring out some of the things that I want to talk about. A lot of times we'll get a transfer early in the evening around 9 o'clock. This one, coming from another hospital, unfortunately ended up turning out to be pretty ill, requiring a heart shock triage. And around midnight, a lot of times there'll be this episode of hypotension, which for me involves sorting out whether it's physiologic, pathophysiologic, or iatrogenic, potentially from the afterload reducing agents that were given during the day or the overly aggressive diuresis. And then unfortunately, sometimes we get code blues in the middle of the night that we have to run to and drop everything for. There's then subsequent transfers that also happen later in the night. We in the Pacific Northwest kind of get patients from all over the area. Some of them fly out to us, and when they arrive to us, it's much later at night than when they leave. And then sometimes at 5 or 6 in the morning, things quiet down, but not always. And some, unfortunately, there's nights where they hear from the cath lab that they were activated for a STEMI, and then that becomes another rushing around job before finally can leave at 7:30 in the morning. So we are all aware of circadian rhythm, that is processes that happen through around the span of a day. So the circadian term comes from the Latin describing around the day. In the 1970s and the 80s, there was increasing recognition of circadian rhythm in cardiovascular disease. Improving study techniques and technologies were developed that allowed us to detect these rhythms. This comes from the myocardial infarction is kind of the bread and butter of us in cardiology, and it was one of the first cardiac diseases where circadian rhythm was noted. This study comes from the multi-center investigation of limitation of infarct size. It was a study done to look at the value of various therapies such as propranolol or hyaluronidase for acute MIs. It was a database from 1978 to 1983 with extensive information of MI patients admitted to 5 CCUs. In almost 3,000 patients, they had CK elevations that confirmed the MI. 703 of those patients had serial CK-MB levels that were measured by a core lab to determine the onset of the MI. Here they noted a circadian periodicity with a peak MI incidence between 8 a.m. and 6 a.m. and noon. And they also comment on this kind of required her lull of MIs in the 6 hours before the peak. Previous studies have noted the circadian rhythm in myocardial infarctions, but this was the first study to correlate onset of MIs with biomarkers and not just subjective pain. But obviously, we cannot talk about cardiac studies without discussing the Framingham study. As more evidence began to accumulate about circadian rhythms in MIs, the Framingham group looked at sudden cardiac death in their prospective cohort that they've been following since 1948. Recall that Framingham was one of the first longitudinal studies, so they had specifically defined and tracked sudden cardiac death from the very beginning in the 40s. The timing of death was determined by witness interviews, medical reports, including autopsy and newspaper accounts. Remember, this was a study that started in the 40s, so sometimes they had to just go to the newspaper accounts of the death, as well as death certificates. However, not all deaths could be determined. Here, they assumed that the undetermined time of death were evenly spread out through the 24-hour period. So you can kind of see that with those black boxes at the very bottom that they've spread out throughout the 24-hour period. Those found dead in bed were kind of split evenly between midnight and 6 a.m. They split the difference between those that they had a known time that was last seen alive and then subsequently found dead. So they just put it right in the middle between found dead and when they were last seen alive. And if they were only able to get timing within a quarter of a day, then they spread it evenly amongst that quarter. So whether it was like the midnight to 6 quarter, or the 6 to noon period, and noon to 6 p.m., or the 6 to midnight period, they spread it in that quarter. Amongst those with sudden cardiac death that they could determine the timing of death, there was a clear kind of circadian rhythm. Those are the white clear bars where you can see there's this peak once again in the 6 a.m. to noon region. And once again, there's kind of a little bit of a lull in the earlier morning hours before that peak. Obviously, the study was limited by the ability to determine precise time of death for everyone. So there has been advances in technology that allow us to more precisely define causes of a sudden cardiac death. So ICDs are this obvious advancement that allow us to precisely time when the potentially fatal arrhythmia begins. This was a study that looked at 483 patients with a Ventec ICD and the timing of the tachytherapies. The left panel shows timing of tachytherapies for what they defined as slower tachyarrhythmias, that is, those with the heart rate less than 250 beats per minute. On the right panel is the timing of tachytherapies for faster, greater than 250 beats per minute tachyarrhythmias. Both showed this peak once again, kind of in the morning hours, 6 to noon, with this lull before kind of the midnight to 6 period. They noted that there's even the smallest decrease was actually in the 3 a.m. to 6 a.m. period. This was the first study that could use more advanced technology to precisely time the cause of sudden cardiac death. In addition to MIs and sudden cardiac death, multiple studies also started showing circadian rhythm in strokes. This was a 4-year community stroke study done in the United Kingdom. They had 675 first ever strokes and were able to determine the time of onset in 554 patients. They did assume that the time of those who awoke with a stroke, that was the time of the stroke. Much like MIs and sudden death, they found circadian rhythm with the largest number of strokes in the 6 a.m. to noon period. So multiple studies through various methods have found a circadian rhythm with myocardial infarction, sudden cardiac death, ventricular arrhythmias, and strokes. In particular, there seems to be this overnight decrease in this midnight to 6 period, followed by this 6 a.m. to noon period around the time of awakening and after awakening. So what's the cause behind this pattern? A basic review of the circadian rhythm. We get our day-night cycle cues from the sun's input that goes through our retina into our suprachiasmatic nucleus in the hypothalamus. The suprachiasmatic nucleus helps coordinate rhythms in all organs and cells. In the cardiovascular system, we see circadian rhythm in blood pressure and heart rate, with decrease in both at night and increases as we wake up. For me in particular, this contributes to this nightly conundrum that I have about hypotension, whether or not it's because of the regular circadian rhythm or something else more concerning. In addition to blood pressure and heart rate, investigators started looking at other potential biologic processes with circadian rhythms to see if those could be contributing to the circadian rhythm noted in cardiac diseases. We now know that platelet activation is associated with myocardial infarctions, but that was not clearly known around the time that circadian rhythms were being noted in cardiac disease. Here's a study looking at platelet aggregability in healthy males. The investigators drew blood every 3 hours over a 24-hour period to test platelet aggregability to two stimulators, epinephrine and ADP. These individuals were admitted to a clinical research center overnight, with all of them sleeping from midnight to 8 a.m. They were awakened at 8 a.m., showered, had a cup of coffee, and walked up and down 3 flights of stairs. They found the 3 flights of stairs they were asked to walk up and down was to simulate morning activity. They found that there was a significant rise in platelet aggregability as measured by lower concentration of epinephrine or ADP needed for platelet aggregation when comparing the 6 a.m. to the 9 a.m. period. So there was, for both epinephrine and ADP, they required lower concentration of them to aggregate the platelets. Obviously, one criticism of that study was that while mimicking the real-world waking activities, changes in platelet aggregability reflected physical activity and not necessarily circadian rhythm. So subsequent investigators came up with this idea of a forced desynchrony protocol where participants live in a non-24-hour cycle of waking and sleeping. Participants in this study were admitted for 13-day stay in a private lab room with constant dim light, free of any time cues. For the first 2 days, they had a standard kind of day where they were scheduled to be awake for 16 hours, followed, that's in the kind of a thinner line, followed by scheduled to be asleep for 8 hours, as noted by the thick black bars. They subsequently forced the day shorter on them, where they had 12 20-hour days with 13 hours and 20 minutes where they were scheduled to be awake, followed by these shorter 6-hour 40 minutes sleeping sessions. So eventually they essentially shifted their clock, their sleeping periods over so that they were sleeping during the day and awake at night, almost like a kind of shift work kind of setup. They did multiple platelet studies with several blood draws, hourly blood draws. The results are listed here kind of in a double plotted where the data are repeated back to back. Most of these panels on the left, as well as the top 3 on the right, are of platelet function, aggregability, and size. They all show that there was circadian rhythm to increasing platelet function and aggregability in this kind of what would still be this 24-hour period that you'd have, kind of irrespective of this forced sleep-wake cycle that they were enduring with the desynchrony. The one thing of note they also looked at was epinephrine levels here. You can try to make that out in the lower right-hand corner. They looked at kind of epinephrine as catecholamine with this catecholamine surge that happens in kind of what would typically be the waking time of individuals, and then this decrease in times at night. Years before that forced desynchrony study, I was involved in the study looking at circadian rhythm and norepinephrine levels. I was an undergraduate lab grunt running high pressure liquid chromatography to measure norepinephrine levels in heart failure patients, perhaps in a bit of foreshadowing of my future career. I remember running these samples in the middle of the night when I had free time. Our group did this study because there were several studies looking at catecholamine levels as a predictor in heart failure patients, but our group was concerned because there was a known circadian rhythm in catecholamines in healthy individuals, as the last synchrony study showed. This was a small pilot study of 9 individuals, 6 with heart failure as represented by the squares, 3 controls represented by the triangles, admitted to a clinical research center for 24 hours where they had hourly blood draws. None of those individuals were on any beta blockers. We did find that there was that heart failure individuals had a significant lower norepinephrine level in the midnight to 6 a.m. period compared with this, the 6 a.m. to noon. You could kind of see this peak in those morning hours. There was a suggestion that there was a greater variability and higher norepinephrine levels in heart failure individuals versus control, but obviously small sample size, so that wasn't significant. So I've discussed some of the physiology and pathophysiology that may be underlining the end cardiac disease states that we see with circadian rhythms, namely increased platelet activity, prothrombotic milieu, as well as increased catecholamines, which brings up the question of possible interventions that we could try to alter the circadian rhythm in cardiac disease. If only we had a common interventions that affect platelets and catecholamines. I'll touch on those interventions and bring up another forced asynchrony that many people experience each year. So this headline is a couple of years ago would not have been a controversial statement. While in recent years that there's been data that has downgraded the general use of aspirin, it still remains a bedrock medication used by us in cardiology. It is the thing that medics give to patients with chest pain, is 325 milligrams of aspirin. And the Physicians' Health Study was one of the landmark studies that pushed aspirin use. It was started in 1981 and enrolled over 22,000 male US physicians and followed them for over 5 years in a randomized double-blind placebo-controlled trial with aspirin 325 milligrams every other day. It found a 44% risk reduction for primary prevention of myocardial infarctions with those randomized to aspirin. The aspirin portion of the study was actually terminated early, partially because of such a significant risk reduction. So the Physicians' Health Study was done around the time that those publications were coming out about the circadian rhythm and myocardial infarctions. And so the group looked to see if there was a circadian rhythm amongst the myocardial infarctions in the Physicians' Health Study. They examined 342 of the non-fatal myocardial infarctions and were able to determine the time of the infarct by blinded chart review in 211 of those myocardial infarctions. The top panel shows all of the non-fatal MIs by time of day, regardless of whether they were taking aspirin or placebo. As before, there is kind of that standard kind of peak in that starting around the 6 a.m. period, as well as a little bit of lull beforehand. The middle panel shows that the circadian rhythm remains in individuals who are randomized to placebo. So there's kind of this morning peak still of myocardial infarctions. However, the bottom panel are those individuals who are randomized to aspirin, and those physicians, they don't, you no longer see that morning peak, and the circadian rhythm is significantly blunted. So in addition to aspirin, the other interventions that we have is for catecholamines with beta adrenergic blockers. This was a small study done at SUNY Stony Brook where they had 19 men without angina, but somehow ended up with a positive exercise treadmill test and coronary angiogram showing significant coronary lesions. The 19 men wore 48-hour Holter monitors at baseline to characterize ischemia by ST depressions. They then took propranolol 80 milligrams daily, and 5 days later had another 48-hour monitor to characterize the ischemia on the propranolol. In the kind of the white empty bars, you can see the ischemic events as noted by the ST depressions on the Holter monitor before they had started propranolol. So you can see once again this morning kind of 6 a.m. to noon peak, as well as this kind of lull or nadir before that peak of ischemic events by ST changes in individuals without before they took the propranolol. In the kind of the hashed bars, you can see what happens after they've taken propranolol for 5 days, and that there's a significant decrease in ischemia overall, but as well as kind of in these ischemic events without the circadian rhythm. I'll touch on this other study kind of briefly that looked at calcium channel blockers separate from beta blockers with the circadian ischemia. These individuals also had Holter monitors to evaluate ST changes for ischemia in addition to diary with timing of angina. The left panel shows ischemic episodes by time of day on and off atenolol, and the right shows ischemic episodes by time of day on and off nifedipine. Atenolol blunted the circadian rhythm, so you can see this is kind of off the higher bar, higher line as the off of atenolol, and then the lower line here represents on atenolol, with this top frame being the Holter events with the ST changes, and this by the angina recordings on their diary. In the right panel, you can see the effects of nifedipine, or essentially the lack of effects of nifedipine. There is still a circadian rhythm even after starting nifedipine with the kind of this dotted line. There is kind of a modest decrease in ischemic events by ST changes and as well as by diary recordings, but it did not really affect the circadian rhythm. One could argue that atenolol in this instance decreased the number of ischemic events much more than nifedipine, and perhaps just needed higher doses of nifedipine to see whether or not nifedipine could affect the circadian ischemia. So aspirin and beta blockers affect the circadian rhythm of cardiac diseases. Our own SCUD-HEF trial found a disappearance of the morning peak and sudden cardiac death in their participants who were randomized to receive an ICD. Recall that these were heart failure subjects who were enrolled between 1997 and 2001 and randomized to either placebo, amiodarone, or a primary prevention ICD and followed for sudden cardiac death. Of the 811 individuals randomized to an ICD, 70% were on beta blockers. There were 714 total appropriate therapies in 186 subjects, with 56% of those subjects on beta blockers. The surprising finding in this study that Chris Patton and her colleagues found was that there was a lack of that 6 a.m. to kind of noon peak of ventricular arrhythmias. They speculated that this decrease in this circadian rhythm might be due to the fact that more heart failure individuals are on beta blockers and might be modifying that. This was from an interrogation that I did recently at night. I wanted to include this kind of as a transition to another alteration that we do that affects circadian rhythms, one not necessarily in a good way. Daylight savings time. It was originally proposed by Benjamin Franklin as a joke to economize candle usage, but it was increased. There was increased implementation during World War I to conserve coal. With daylight savings time, when we implement it, we spring ahead, where we essentially lose an hour, but to gain more daylight during the waking hours. And then in the fall, we fall back and have an extra hour of sleep to transition us out of daylight savings. Several studies have looked at daylight saving switch and its effect on myocardial infarctions. Here's a meta-analysis of 5 studies with over 45,000 patients with myocardial infarctions that happened in the week following either the spring forward in the light gray or the fall back in the dark gray. They compared MI admissions in the week following the daylight savings change to the 1 to 2 weeks before and after the switch week. While the fall back out of daylight savings was not as clear, there appears to be a higher occurrence of MIs in the week after we spring forward into daylight savings. There's lots of speculation about the effect of 1 less hour of sleep during that time and the increased stress causing increased MIs. There have been other studies showing other harms additionally with the daylight saving switch. So there's been an ongoing push to get rid of the daylight savings change. In the same vein as Benjamin Franklin's joke proposal to institute daylight savings, one could imagine proposing to take aspirin and beta blocker in the weeks before and after daylight saving switch to help blunt the effects of that daylight savings change. So I've gone over the circadian rhythm in the presentations of our cardiology patients. Now I want to switch over to circadian rhythms in our cardiac care. Going back to my typical nightlife, I want to focus on the morning MI and the middle of the night codes. Several studies have looked at those off-hour presentations of these cardiac events and found that there's been unfavorable results when they happen in off hours. This was a study published last year looking at door to balloon time in ST elevation MI patients in a prospective English registry. They used the National Health Service definition of what regular hours were of 8 a.m. to 6:30 p.m. and definition of off hours being between 6:30 p.m. and just before 8 a.m. They looked at primary PCI with 24/7 interventional centers and found that there was a longer door to balloon time during off hours versus regular hours. They also found an increased 30-day in in-hospital adjusted mortality related to the increased door to balloon times. This increased mortality was attenuated when including admission time, suggesting it's not all just the longer door to balloon time. It's not surprising that there's an increased door to balloon time in off hours because we don't typically have personnel on site. So things would be expected to happen slower at night like everything else. In addition to the MI care overnight, there's also differences in outcomes with in-hospital rest. This was a study looking at in-hospital rest and how time of day affects outcomes. It was an AHA-sponsored voluntary multi-site prospective registry of over 500 US hospitals looking at in-hospital arrest between 2000 and 2007. They excluded cardiac arrest with resuscitation that was initiated out of the hospital and looked at only those where the first arrest happened in the hospital. They excluded also VT and VF events that involved an ICD. Here they define day and evening hours as being between 7 a.m. and just before 11 p.m. and night time as being between 11 p.m. and just before 7 a.m. They chose the 3 p.m. hour to represent as the reference because that had the highest survival. You can see kind of that throughout by hour of the day, survival is highest at 3 p.m. kind of midday, but then gradually gets worse. And then overnight, there happens to be kind of the worst survival with in-hospital arrests. The authors noted that night arrests were less likely to be monitored by telemetry or to be witnessed. Night arrests also had higher rates of asystole and PEA versus pulseless VT or VF as the initial rhythm. They also looked kind of at this weekend effect. Here's the survival to discharge rate by the day of week that the arrest occurred, separated by whether the arrest occurred in the day and evening hours, kind of in the white bars versus the nighttime. Once again, kind of the survival to discharge was worse if the in-hospital arrest occurred during the night hours and better if it was during the day and evening hours. However, over the weekends on Saturday and Sundays, the kind of difference was much less notable. So it is literally kind of a night and day difference in the staffing between days and nights. In our own UW-Montlake cardiology system, we have 8 separate inpatient services that provide primary care for cardiology patients. During the day, there's 14 to 16 providers on our floor services that are covered by 2 providers overnight. It probably doesn't take a lot to figure out which days of the week are covered by 14 providers versus those covered by 16 providers. This kind of points at where we also get the weekend effect. In our 2 unit services that we have 2 nocturnists covering for 8 to 10 daytime providers. This isn't surprising because so much more happens during the day, obviously, but this is a microcosm example of what may explain some of these differences in care depending on when cardiac events occur. There's also a difference in seniority. I happen to be one of the longest serving night persons in our hospital, excluding our ED providers. And we also happen to have a much higher turnover at night. Nurse staffing also tends to have more junior individuals. And every quarter we get 3 to 4 new nurses just out of nursing school. I know more recently we've done a better job at not making all of the new nurses start at night and instead allow them to have kind of a day-night rotation system for the new nurses. So when you have less staff and more junior individuals, less stuff gets covered. We recently had an M&M on a patient with a balloon pump that was moved late in the day. I, in a rotating crew, ended up holding the groin for almost 3 hours afterwards. It just served as a reminder to be careful in terms of timing when you do things, because you have to anticipate with staff changes and short staffing. Also, there's this issue of kind of what happens overnight when adjusting devices like an Impella. We're currently in the process of trying to train more of our night individuals to adjust Impellas, but not everyone on overnight has as much experience with these devices. And so sometimes it becomes an issue. I know we call our cath lab a lot of times to discuss about potentially adjusting Impellas for various reasons. Finally, I want to discuss another cardiac issue that happens in individuals with kind of a prolonged forced asynchrony. Those are shift workers and the cardiac consequences of shift work. Shift work is known to be associated with increased risk of diabetes, hypertension, metabolic syndrome, and dyslipidemia. These are all risk factors for cardiovascular disease. Here's a meta-analysis of 34 studies in over 2 million participants who were shift workers and their risk of cardiovascular disease. They included studies with the prospective cohort, retrospective cohort, and case control through the end of 2011, and found that shift work was associated with an increased risk of both MI, coronary events, and ischemic strokes. Additionally, there have been studies showing a dose-response relationship between the length of time doing shift work and increasing risk of cardiovascular disease. This was a literature review of 21 prospective or case control studies that were done between 2006 and 2016 with over 173,000 participants. They did a meta-analysis on 5 of those studies that presented risk estimates of cardiovascular disease based upon the years of shift work done. They found a 7.1% increase in cardiovascular disease risk for every 5 years worked beyond the first 5 years. I'm currently heading into my 13th year of working in nights, so I would happen to be up here. So what can I do about this? There was a recent small study that was published looking at exercise training in shift workers who worked at 2 Norwegian insulation producing factories. The workers were offered supervised exercise training sessions on the work site either before or after their shifts, 3 times a week for 8 weeks. It was only a 17-minute exercise protocol, with the peak being of 4 minutes of around 90% max predicted heart rate. There were 19 participants that completed at least 10 of those training sessions, and they compared them with 37 participants who did not get to 10 sessions as their controls. Because it was such a small study, there were actually no significant findings, statistically significant findings, but they did comment on a trend in improvement in hemoglobin A1C, BMI, blood pressure, and cholesterol levels. So there is still hope for me yet. For those who don't recognize this photo, this is from our own crow's nest where most of our call rooms are. Someone has tried to encourage kind of healthy physical activity. I know I've used the elliptical once, and in my 12 years of working nights, I have seen someone using the treadmill once. And this is me on my Peloton. I'm usually doing it during grand round, but obviously not today. I'm not going to go into the data for scheduling because it's not related to cardiology specifically, but there are other things that can be done from an individual shift worker's perspective on optimizing scheduling and function. There is a suggestion that napping before night shifts improve cognitive ability and decrease nighttime sleepiness. Also, some data showing that minimizing the number of consecutive nights limits the accumulation of sleep debt. So I end kind of where I begin with my nightlife, except perhaps I bookend my schedule with a nap and exercise afterwards. And with that, I'm welcome to take questions and discussion.